Yes, I'm here. So I have a naturally kind of soft voice, so I'll try and talk pretty obnoxiously. So forgive me if it's a little overboard because I'm trying to make sure you can hear me, and it's kind of like giving a presentation blindfold because I don't know who's sleeping or not. I'm sorry I couldn't be there in person or even in video. I work at a jail, so not a lot gets in and out easily, including streaming video apparently. Um, to just give you a brief introduction, I am a 2009 graduate of ELAM that Dr. Leramé mentioned. And I am trained in family medicine, and I work in what I like to call a different view of full spectrum family medicine, which is if you look at underserved areas, oftentimes a common endpoint is incarceration for very wrong reasons for a lot of things that we've been talking about today. So I like to say that I like to take care of people in different stages of their life, and unfortunately incarceration is one of them for a lot of underserved areas. So I work at the Cook County Jail, which is the largest single-site jail in the country, nothing to be proud of. And we have about a capacity of about 10,000 people. And we're a part of the Cook County Health and Hospital System, which is something that I won't go too deep into detail, but it does have something to do with my medical education in Cuba, in just that it is a community-based system, a county-based system that sees the people that are incarcerated in the county of Cook, including Chicago, as part of the people that it should care for, which I think is pretty awesome. And so we try to provide the best care that we can to all of our people that live inside our Cook County boundaries. Next slide. So I won't go too deep into detail, but I thought I would be greatly amiss if I didn't just make a word or a statement to say that it could take a whole semester to talk about the Cuban healthcare system. And I don't pretend to even approach all that they have taught us or all that is included in their healthcare system. But it's also impossible to talk about the healthcare system without just mentioning that it is a part of Cuba. It is a part of their culture, and it is a part of their politics. And similarly, ELAM, or the Latin American School of Medicine, is really not the best example of Cuba. It is just what they do. It's one of many examples of their healthcare system and about their training. And then similarly, I would be amiss if I didn't kind of just put a line out there to say where I come from. It pulls into the presentation later when we talk about selecting participants for the medical school. I grew up in Philadelphia, and by all means should never have become a doctor. In the middle of West Philly, in the middle of the 80s with the crack cocaine epidemic, and I have nobody's business being a doctor. And so this is really kind of the people that ELAM and that Cuba sought out because they felt like they would be the most likely and the best equipped to go back to that same community and serve the people that are there. Next slide. So one of the biggest things that I just find, my only exposure to medical education initially was just Cuba. It was just what I saw there. I had a community college education in nursing, but I didn't really have a really good idea of what happened in medicine here in medical training. But as I came back and I went through residency and kind of worked in recruitment for residency, I started to pick out some of these things that like, hey, this is actually kind of different. And one of the biggest things is that we received a training of about 12-week rotation, which is as long as some of the other major like surgery, OB rotations in specifically just public health. We are integrated into family medicine rotations every year. It's a 6-year program from the very beginning. And just like was mentioned in the previous presentation, everyone graduates first as a family physician. And you work for your internship for a year as a family physician, and then you can specialize in whatever you need or whatever you desire, but the idea is that you will always need those skills to go with you, no matter what you decide to specialize in. The curriculum oversight, actually, and the construction of the curriculum is through the Ministry of Public Health. So it's no secret, and that's a good reason why there is this infiltration of public health into every rotation. And then finally, we had even though we had a 12-week course just specifically on public health, we had additional rotations that were required, including dengue rounds. So we all know in South Florida and in the Caribbean and in Cuba, of course, dengue is endemic, and it has its seasons where it flares up. And so we would have rotations where we had to go door to door in dengue rounds, visualize the water sources, visualize where people were storing water, talk to people about fevers and about education about dengue, take temperatures, and move on our way. And we would compile all that information. We were assigned a certain area, compile the information, and then that actually was used later in the national statistics into what areas to target. And then further, we have a rotation in disaster medicine, which I think was really cool. When you think about it, a lot of the colleagues at the school were from Caribbean and Latin American countries, so disaster medicine was very appropriate for them. But what was really interesting was that the American students, or any student, was encouraged to use a disaster that would happen in their area. And so since I'm from Philadelphia, there's not a lot of natural disasters going on there. I was allowed to use the homicide epidemic as a disaster and to analyze where it comes from and what could be strategies to implement to make change. And so that's really key to our training there, is that when you're training people from hundreds of different countries, you have to really tailor it to what their need will be later. Next slide, please. As I mentioned before, and as was mentioned in the previous presentation, primary care is the focus. And really, if you think about it, this wasn't by accident. This came out of Cuba has a great way of adapting to change. As things got more difficult financially, and after the special period, the focus became more and more tuned onto primary care because, well, we have to be able to adapt. If we no longer have the medications that we need, well, we need to figure out what complementary and alternative medicine will work, because we got to keep moving. And so it wasn't completely by accident that this attention to primary care was brought up. But nevertheless, it is the cornerstone of the healthcare education and the health care system. We talk a lot about the patient-centered medical home model, which we know has been able to achieve great outcomes with little resources. And in Cuba, one of the first, the equivalent of the model came out in 1967. So this is the model that we were immersed in from the very beginning. It's very heavy on disease prevention and health promotion. We talked about every specialist first being a primary care physician. And then the other thing is the key role that primary care physician has in population surveillance. And we'll talk a little bit about that in a minute, but it is not just your job to know the individual that's sitting in front of you. It's your job to know all of the individuals and the families and the little subunits that occur out in your designated area. And so they really play an important role in detecting disease and preventing disease out in the population. Next slide, please. One of the things that we like to think about first when anybody thinks about Cuba is say, oh, well, access to care, right? It's free, so therefore it works. But we know when we've done studies that being free isn't enough, or just having access to care isn't enough. So I think a lot of us, when we first went to Cuba, we said, oh, man, a lot of us had grown up without any access to care or hadn't had insurance at the time. When I was doing my pre-med school physical for Cuba, I had to go to a free clinic. I didn't have any insurance. But, so initially we start to think like, oh, wow, this is great. Like, we'll be able to become doctors. We'll come back. We'll just kind of plan ourselves out on the sidewalk, and we'll pick people up. We'll be able to cure them. It'll be great. And it kind of, over time, you realize that to say that it would be to ignore all of the wonderful work and systems-based care that Cuba has really constructed. The piece of actually having, free care is very small, actually. We know that in the United States, there are poor outcomes for African-American men and for African-Americans and people with lower socioeconomic backgrounds, even when you control for access to care. But nevertheless, it is still an important issue. And the other thing I wanted to bring up, and this is again about this adaptation, this part of this Cuban culture, which is to adapt to whatever trouble you have, is that it's financial access to care, but it's also geographic. So think of how key it is when you're going through, you've got this huge country and lots of population, and actually initially when you think about it right after the revolution, a large majority of the doctors left, and so now how are you going to get to these people and to take care of them? Well, you plant a doctor there. You plant a doctor right there where the clinic will be, and that's how you'll take care of them. So it's very much a geographic aspect to care as well, especially in times where transportation can be difficult. And then continuity of care, obviously, so the same doctor that, took care and took part of your prenatal care, that did all of your well child visits, that then is doing family planning with you later, will see you after you have your kids. We all know about the benefits of that continuity of care, but also at a systems-based level that, you are getting a standard of care that's across the board. It is designed by MNSAP, by the Ministry of Public Health, and it has common clinical guidelines across the board. So if you go from here to your polyclinic, from your polyclinic to the hospital, theoretically you should receive the same level and amount of care appropriate to each level of medicine. And then outreach medicine, this kind of goes back to what I was saying. If you can imagine half or more, probably a good 2/3 of the doctors left, and now you're left the country, and now you're left with a third, and of course they all want to stay in Havana. You have to figure out a way in order to get them out, and so one of the ways that they devised it was this outreach medicine, that the doctor will go to the patient, that you are assigned to a certain group of people, and they are your people, and if they don't come, then you need to find them. I think I'm going to get into that in the next slide. But one important part that I like in this one that is really kind of light years before its time is this idea of ingreso en el hogar, which is the family physician can decide that someone is pretty sick, but maybe for social reasons or maybe for other medical reasons, they can't go to the hospital or it wouldn't be a good fit. Well, they can admit them to the house, which basically means I may have done house visits for you before, but now I'm going to visit you, every day. A nurse will be there 3 times a day. Maybe she's going to change your dressing and, things that we have done here in the United States, but is really maybe not as utilized as much as it could be. Next slide. So we talked a little bit about the family physician and the family nurse being the hub, and that consultorio, which is their doctor's office, is really the hub for everything. So not just, again, you come in, you have a cold, you come in, or you are with it enough and not using drugs and not chaotic, your life is straight and narrow enough that you can decide that you go in for your well visit. Well, that's great, but also that doctor and nurse pair will be going out to you to find you. And that there will be activities based on that nurse and that doctor going around and saying, in our population, we have a lot of elderly people, so maybe we need to do some interventions for the elderly. And so, it's not uncommon that in one consultorio there might be stretching and strengthening exercises every morning, whereas in the next one there isn't. And that's basically because of the population oversight that they've done. The nurse's risk stratification, and it's based on biological factors, which are really kind of end up being a smaller part of it. Obviously, if somebody had a heart attack, then they are a higher risk than somebody that's never had a heart attack. But the really unique part about it is that it includes also psychological and social risk factors. So the woman who her whole family left and went to the United States, she's a higher psychological risk than the person that has all of their family there. The newborn is a higher biological risk than maybe the 5-year-old. Not by much, but a little bit, right? The 19-year-old that's not working and not in school, they're a higher social risk. The woman that is of reproductive age that doesn't have a plan for when she wants to get pregnant, she's at higher risk. And so they're assigned a number, 1 to 5. Each individual in the family nucleus is assigned a number. And so then that person is visited or has visits based on their number. So if, let's say you're just a healthy 40-year-old with no real problems, maybe we'll see you twice a year. And that twice a year, once you have to come into us, into the clinic, and once we have to go to your house. And why? Because, well, we might get different things from you in the clinic because you may not want to tell us stuff around your wife. And I want to see your house. You might be telling me you don't smoke and you eat vegetables every day, but I can't really see that, So there's this feeling of going to the house. And also, again, going back to that Cuban culture, it is very common to have the doctor be a part of the family and to come and visit anyway. But the way it's designed is to have both views of that individual. And then the integration of political and social groups for disease prevention and health promotion. Well, the doctor and the nurse can't do it all. And the best way that you can involve people if they're, a little shy of doctors or don't really want to go see the doctor is have, that neighborhood committee to go around and design who's going to, which houses most need the dengue rounds, or, the women's committee might be able to do a campaign on breastfeeding, and they work together with the consultorio. Next slide, please. And then social medicine. We talked a lot about this, and I think that this is probably the most understated slide. I mean, this is exactly why we're meeting, but it's just to kind of highlight the fact that the Cuban medical training model, it puts social medicine first, that everyone is a biopsychosocial first. And as the previous presenter said, the biological is often very minute. There's a lot of other things that go into play. And then also the idea, we all know about this global burden of disease, so that poorer countries are going to have higher quantities of disease. Well, same thing in Cuba. Cuba is not without class, and it's not without race, and it's not without the disparities that are attached to those things. But the idea is that when you see that division, and we know that that very division, that very gradient is what spurs the gradient in health outcomes, that you should attack it head on. So seek it out and attack it. Next slide. So in the end, to kind of funnel it out, if I were to be this example of this Cuban training, which is a lot to weigh on my shoulders, but Cuba and my training there did very much play into where I wanted to work. I told you initially I just thought, I don't know, I'll just graduate. Well, to be honest with you, initially I just never thought it would come true. So every day it was just like, I'll just keep chucking, and one day I'll just see and I'll look up and I'll be done, and that's kind of what happened. But once I was done, I thought about it and thought, it's not enough to just plop down and say, I'll be a good person and a good doctor. I wanted to seek out not just working in an area that shared the geographic boundaries of underserved communities. I wanted to work with that community. And I wanted to work in a system that, may not be perfect, but that a system that attempts to decrease these disparities. I wanted to have outreach medicine, which is why I chose the jail. It's interesting because I sat down in my last day, or my last year in residency, and I was in the health disparities track, which was a track to, we got like a HRSA grant to be able to increase the number of primary care doctors that worked in underserved communities. And I always thought, every community I just was so interested in. I wanted to learn so much more. But what's really sad is that if you're a family physician, sit down and calculate what percentage of your patients are young African-American men. Very little, I would guess, because how many of them are seeking you out and coming to you for their adult visit? I'm not talking about pediatric patients or elderly patients or even, your middle-aged patients. I'm saying that the 18 to 40s, how many? Very little. And so I thought, if I want to reach that community, I have to go to where they are, and that's part of the reason why I'm in the jail. Obviously, a big reason as to why I chose primary care and why I chose to work with underserved communities. The next thing was interesting because it's actually one of the things that was brought up in the previous presentation is that, like I told you, I really had no business being a doctor. And that's exactly what the school wanted to find, because they wanted you to be able to go back to work in those communities. And we know that, African-American providers, for instance, were only 5% of doctors in the U.S., serving 13% of the population, or if our equivalent would be 13% of the population. We know that there are trust issues when it comes to African-American community. And so I thought, if I'm a person that has had a lot of exposure to the criminal justice system, not necessarily personally, but in my family and in my community, then there might be something that I can see when I'm working with patients that would cut time and cut effort. Doesn't mean that the next provider doesn't. Actually, all of our providers at the jail do wonderful work, but I liked that closeness, that intimacy with my patient, that there doesn't have to be shame there, that I can understand their process. And so I think that that's one of the strengths of our graduates, is that we are coming from the communities that we serve. And then finally, we talked about the full spectrum care. So finally, I would say one of the things we like to say that we do at the jail, or I like to say, is we do a little cortadito, like a little espresso shot of care, because this person might come in and be gone the next day. They might be gone in a couple hours. Particularly in the prenatal clinics, you might get a woman that got, picked up for a dirty drop, and now, you only got one day before she's going to be out again, and maybe doing prostitution, and maybe heroin, and maybe all kinds of things. And so you got to get as much care you can in one little visit. And so that's probably of my entire job, that's the one thing that reminds me the most of Cuba, is just prevention, prevention, and prevention. The last one, I had an idea of how to bring this about, but I think we're probably running out of time. But if you were able to read it in the next 3 slides, probably because I broke it up, is just this is a story of a guy that was at the jail, and these are endless, day in and day out, every time. But I tried to imagine this man if he had been in Cuba, or if he had been the recipient of one of our medical training models of care. But basically, he was just a Polish guy that got hooked up for a DUI, I think, or driving without a license. And he wanted, the nurse in the receiving saw him to have like a, moistness on his shirt, and so she wanted him to be seen by a doctor. And initially he was like, no, I just want to get out of here. It's going to delay my time. And eventually he allowed me to see him. And he had this massive, like 20 by 25 centimeter wound all across his neck and his upper chest. He couldn't really even tell the history of how it got there. Of course, he had some alcoholism issues. He was really worried about getting home to his wife because she was deaf, and he couldn't call her to make her, so that he could get his bond made. And it just was this spiral of all the social determinants of health you can imagine. And in the end, in the jail, he was able to get a biopsy, and it was basal cell carcinoma, and he was able to get a skin graft. But it just really kind of touched home to me as this is exactly what they were trying to teach in Cuba. So I don't know if I was able to get that all fully across, and I'm quite sure it wasn't 10 minutes, but that is the sum of my presentation.
Thank you so much, Lillian.